Good morning. My name is Jackie Klotz, and I want to welcome you to our webinar by Dr. Cecilia Ganduglia-Cazaban, who will talk to us about improving health through data, understanding your patient population needs to maximize impact. I'm grateful that you all have joined today for this session of our webinar series. We want to know your name and what you do in the NMDOH space, so please comment in the chat box. This meeting will be recorded and shared on our YouTube channel after the event. And just to note, we will also be emailing a copy of today's slides for your reference. There will be time after today's presentation to answer your questions, but as questions arise, please post them in the chat and we'll monitor them to make sure they're addressed following the presentation. Now, without further ado, I want to introduce our consortium founder and senior advisor, Elena Marks, to tell us about today's session.
Thanks, Jackie. Thanks to all of you who are with us today. This is exciting for us today because our speaker is one of our co-founders of the consortium, and it's always good to have her actually in her work mode and not in her founder's mode. So Dr. Cecilia Ganduglia-Cazaban is the director for the Center for Healthcare Data, which is an amazing resource at the UT Houston School of Public Health. It hosts the all-payer claims database, which is a huge repository of medical claims data. They also have all sorts of other data sets that are really important, and they're available to you. The claims data that they have offers potential insight for NMDOH research and evaluation, with information on cost of care, inpatient and outpatient visits, health outcomes, incidence and disease prevalence in a large number of the population. And so you're going to hear today from Cecilia, who is also an associate professor of management policy and community health at the UT School of Public Health. So she's going to talk you through what kinds of data they have, and she's going to provide you some examples on how you can leverage NMDOH data, whether you have it or whether you can go get it, because there's a ton of it on the internet, to better understand your population. And so whether you're just beginning to use NMDOH data to describe your patient populations, or you're ready to dive into much more complex data use cases so that you can actually address their non-medical needs, the takeaways from this session can be used to identify key issues and inform solutions to improve your patient's health. So please join me in welcoming Dr. Cecilia Ganduglia-Cazaban. Cecilia, take it on.
Thank you so much for that introduction, Elena. So I'm going to share my screen here. Let me make sure that everyone... Okay, can everyone see the slides in presentation mode? Perfect. And so I want to start just by first thanking Elena and Charles for inviting me today here, and thanking all of you for joining us in this sort of gray morning to listen to me and talk a little bit and ramble about what I think and some of the advice that we may have from the data center on how to use data. And I specifically want to thank Jackie and Chloe both for helping us set this up and putting up with me and all the different requests I have for today. And so the idea for today, the other thing I should mention is, as you can all see, I have an accent and I speak fast. I tend to speak fast. And so I know that we're going to have questions towards the end of the session. If you don't understand something or something it's not clear, feel free to interrupt and let me know. I'll be more than happy to clarify. And so the idea for today is really to spend some time learning or discussing how to leverage some of the available data, as Elena mentioned, and particularly on non-medical drivers of health, to better understand your patient and the population that you serve. And basically, it's also to use data to identify some of these key issues and some of the actionable opportunities that this might represent, as this should be, in general, part of the guiding principle when we start working with data within our organization. As Elena mentioned, I'm here today wearing my Center for Healthcare Data hat. I'm also a health services researcher, and I always think of myself more in the maternal child health aspect, but I started really with Trudy Krause many years ago, working on this center and creating a sort of repository for different data sets that we were originally using for research and policy evaluation. But that has actually, and I'm not going to bore you with a lot of details on the center today. That's the link over there that I left for the center if anyone's interested in looking a little bit more into those details. But what I did wanted to share with you, maybe because you are seeing my screen, so I'm going to hide you so you don't see yourself there. And so basically what I wanted to share today with you is the broad variety of data sets and information that's at the center and that's available for individuals to either use or use through services through the center. On your left side, you actually have a description of the type of work and services that we do. And that's the QR code to go specifically into where we have descriptions of our different data sets. And today we're going to focus that we deal with EHR and claims data significantly, particularly with a very specific focus in Texas. We're going to be talking more specifically about Texas non-medical drivers of health information that we have available. Okay. And so I think that's probably more than enough of what you wanted to hear about me. And so we actually want to hear a little bit about you and get to know you a little bit better. And so thank you everyone for introducing yourselves through the chat. I was hoping you could help us get there by answering some questions. And so we basically have two questions that we're going to be polling you today on. And so the first question that I'd like to know is, thank you, Jackie, for this, is to what extent do you currently use non-medical drivers of health data with the goal to better understand your population? And so you have three options here, quite often, sometimes, or you do not use really data at all. And so this is just to help us get an idea of, how to keep going through this presentation and how to structure potential new workshops or presentations that we may use. So I think we have like 20 seconds to answer. So if you can please do that. You tell me, Jackie, when you have the results available and close the.
We're slowing down around 70%, so I think we can take a look.
Okay. Yes, I can see the results, and I think you all can see them as well on my screen. So we have 34% quite often, almost half of you said sometimes, and we still have a little bit over 10% that do not currently use data, but are very interested in using data. So that's really helpful. Let me just write this up. 55 and 11, perfect. And so our next question is, now that I know that a lot of you are already using non-medical drivers of health data in one way or another, now we're interested in learning, how do you currently use that data, right? Do you use it basically to get patient descriptions in their demographics, to learn the geographic areas your patients are coming from and their specific needs, to identify gaps that you could be trying to address, measuring some of the impacts of the services that you provide, probably related evaluate interventions that you may be implementing, or if you may currently have access to data or not do actually data, but might not be analyzing this data specifically.
We're slowing down. I'll let folks put in any last minute answers. And let's take a look.
Thank you, Jackie. So I see that most of you are using really data to identify gaps in services or healthcare utilization. Some of you to describe your patient demographics, and then the other ones are really in small percentages. Some of you are doing actual impact measuring of your services, which is very nice, and understanding where your patients are coming from and the type of areas that those are. This is really good, and thank you so much for sharing. And so I can see from your answers that a significant number of you already have, oops, let me just close that. Now, thank you, Jackie, I'm ready to go on. And so what we can see here is that several of you already have quite a lot of experience with the different data sets. And so the idea for me today is I'm going to basically try to give some practical advice, which is most of what we're going to walk through. And I promise to you, there's only 1 or 2 slides that are more on the background information. And we're going to use this information that you shared with us today to actually help us think about potential for future workshops and who might benefit from those. See if I can get this out of your way. Oops. Okay. Okay. And so part of what I was telling today is one of the things and this is my basically only background slide, but one of the things I feel all the time, or we probably all feel all the time, is that the amount of data we are currently creating is just daunting and overwhelming, right? It feels like almost at every minute or second in our life, we're creating a new data point with anything we're doing, whether it's buying online or buying in the supermarket or going to the doctor or just scrolling through the website or doing searches in Google. Everything is creating a different data point. And healthcare, it's not the exception in this. In fact, the volume of big data is projected to increase faster in healthcare over the next 7 years than in any other field in the world. And that includes finance and marketing and some other very large data areas or data creating areas in our day-to-day life. And in fact, this is another sort of data nugget or informational, but there were estimations that were done between 2020 and in 2020 that had projected, and we're actually very much on track to meeting these estimations, that between 2020 and 2025, the amount of global healthcare data was projected to increase from, this is just numbers, but 2,300 exabyte to almost 11,000 exabytes. So basically in 5 years, more than triplicate the size of all the data related to healthcare that has been collected. And I added there because some of you might not know what an exabyte is, which basically stands for 1 billion gigabytes. And so the little figure on your right just shows you the broad amount of the broad diversity of information that's being created when we think of healthcare, which can go from anything when you think of a healthcare encounter, from when you call in to make an appointment or patients are checking in, to all the way to the health records, the extracts of that are shared across, like in health information exchanges, but also your medical imaging, your genetics, labs information, payer records, vital statistics, registries that are created all the way. We've started incorporating more and more information that's related to health that comes from smartphones or different wearables that are starting to be incorporated not just as data points, but as in the care continuum as well, pharmaceutical, medical devices, and the broad variety of information that's out there. And relatively recently, though we've been asking some of these questions for many, many decades, we've started incorporating into that sort of big bag of data that we do non-medical drivers of health. And this is very much following the whole concept of or the increase in awareness of the relevance of all of this information on our patients' outcomes. And so when we really think about the amount of data that's out there and that one can be using, it really becomes daunting, right? But one of the things that we always sort of discuss, and you'll find in most of the recommendations, is that it really represents an opportunity to refine, if you already have to, or to develop comprehensive data strategies to create more value from what you're doing, more value for your patients, more value for your communities. And so we are sitting in a very sort of important time to actually make sure that we are incorporating these strategies on how to leverage data to improve to add value or improve what we do every day. And so, as I was mentioning with data, yes, in particular with this data growth, the opportunities to innovate are extensive, but resources are not. And this does not just go for your EHR data and how you use EHR. This also impacts our non-medical drivers of health data, right? There is a huge universe of different information that one could be incorporating into the already huge and daunting amount of healthcare data that we have and we have to deal with every day. And so because resources are not, and by resources I mean money and people's time are not infinite, one of the first things that you'd find in recommendations, and some of this I got out of the American Hospital Association, created or published a report on how to leverage data for innovation for hospitals. which has some really nice recommendations, and I'll give you the link in the next slide. And one of the things that you find it's always recommended across the board when you think about data implementation or data use in general, but specifically in healthcare, is to use data with a purpose, right? That's the very first or sort of guiding principle that one might have, because we can spend decades and create thousands of Excel spreadsheet tables and dashboards and portals, and you can just be overwhelmed with information. And so one of the key things when you are resource limited is to actually start thinking about what's the purpose or what's the goal for which you want to use the data. And so that really brings us to some example of questions. I just listed some here, is really going through the process of thinking, what are the most relevant questions that I would like to answer about my population, really, right? And so when you think of population, you could actually be thinking, all your patients, though that tends to be very broad, and you can actually have 100 different opportunities or projects to do in there, where you can identify and think about a specific group of people or individuals that you see or take care of, and really answer the question, how can I improve the care for this population, and what information do I need from them, right? And one of the important recommendations that you always find when you're trying to think about the purpose of using data is to actually identify those insights or those pieces of information that will improve or will modify your decision-making process, right? We all tend to want, and I go there all the time about, I want to see the tables and all the possible descriptives and all the possible 2x2s and all the different percentages. But we really have to find or identify those data elements or those pieces of information that can have an impact on what I do day to day, right? And there's many. I'm pretty sure we can all think of thousands of little pieces of information that can modify our decision-making process. But you want to make sure that that data project, right, or that project with data that you're going to be dealing with or taking on will actually help inform specific things that you can follow and track to make sure that you're using all of this work and all of this investment with a specific purpose that will produce a return on it. And so as you go thinking through that, right, and let's bring this back to non-medical drivers of health, one of the things that you have to identify is what's going to be my data project. And among those, all the different data projects that you can think of, what are my data project priorities, right? Because that will help you inform specific or identify the specific information that you need. And once you know the specific information that you need, then you can actually identify what are the specific data pieces that you need to produce that information. As I think I've saw several of you there are working with EHR data sets. As you probably know, the amount of information you have in the EHR, the amount of variables you may have within an EHR can be infinite. I mean, or feel infinite. They're not infinite, but can feel infinite. And there's issues always with data quality, and there's a lot of work that goes into there. So identifying the specific data elements that you need, because the same is true also from non-medical drivers of health when we think what's out there from an information perspective. It's really important to make this whole process of a data project effective and fruitful. Okay, and so this is the link I was mentioning to you from the report. And so we really started thinking about, that we should have sort of either a guiding purpose or a guiding question behind any data project that we might take onto when we're thinking about healthcare data, non-medical drivers of health data. It's always recommended to identify a population because that will allow you to actually limit or be much more specific on the information pieces that you need and on the data elements that you need, and then on the subsequent decisions or identifying the decisions that you're going to be modifying with that data. And so the other thing is quite often it's not just one piece of information. We always need, in general, additional data elements that can influence that decision-making process. And so whether it's, the number of diabetics that I care for that live in food insecure areas, you may actually also want to know probably their age or their average age, or where you have variation in race and ethnicity. You may want to know their education level. So there's other pieces of data that can help inform that decision-making process, which would be, maybe what are going to be your food recommendations for that population, or where are you going to refer them, and some of these things. And so the other thing that I think quite often I hear personally when I have questions about this, and I often find also cited as issues that others face, is defining your time frame, right? The first thing I always hear from people that reach out is I need real-time data. I need real-time analytics to really inform my decision-making process, and how do I get there, right? But there is also a time frame or a timeline that goes into data analytics. And I think we miss a lot if we just discard retrospective analysis before actually moving into real-time analytics. There's a lot of value that may come that comes actually from looking at what your patient population looked last year or the last 6 months, right? Where do they come from? What were the key issues? What were the problems you have? Because that retrospective analysis is what actually should be informing your real-time analytics, right? And it's not just the analytics, it's your real-time, for example, data collection. Let's say that you're part of an organization that currently is not asking about non-medical drivers of health, or at least not actively collecting non-medical drivers of health data as part of their intake or as part of their process. Knowing what information to ask about, knowing what data elements you need to collect in order to get the information pieces that you need, really requires first looking at who is, who's in your population, where are they coming from, what are the most relevant issues that you identify, and then that can help you inform the real-time analytics. And quite often is that process from retrospective to real-time analytics that then helps you create, when you move into much more developed and advanced analytics, your predictive analytics, right? Looking at the future, forecasting what are going to be your population's needs next year, or in case of weather emergency, right? And really plan for future risks in order to improve outcomes. Okay, let me just look at, okay, we're doing well with time. And so the final really more abstract piece of what I had to share with you today, it's really about going back into the action of what we're going to be doing with data, because that's going to go again and inform what data elements from non-medical drivers of health or from your own clinical data you should be working on. And so we all know that, in reality, collecting and analyzing data by itself does not improve anything, right, in your own practice. Data, the data collection and analysis always needs to be part of a strategy and a system. And it's a system really to address that data point, right? And this goes back to, let's collect information, or let's analyze data that will actually help modify my decision-making process, or whether I'm creating any specific intervention, or how I will address something specifically among my population. And so the ACT part, this comes from Health Catalyst, which is a consulting group, has also another really interesting report on, and this is really more on the life cycle for data. But they actually highlight that the action piece, it's the most important thing, because it needs to be the driver, again, of what you're capturing, integrating, analyzing, and producing information on. And then once you have that information, you can modify again that action intent, right? But you have to have a strategy for the data perspective that includes or knows what that action will be or should be, as well as a system that will support that. And once you have that, then you can actually start dealing with the other issues that you find. I think one of the key things I always share with people is that there's no perfect data set. We'll always have data quality issues. It doesn't matter where it comes from, whether it's your own EHR or publicly available data sets that the census puts out there. There's always incompleteness, delays, inaccuracy, problems with standardization in data. And so knowing that, it becomes really important, because it has to be part of that cycle again, right? And so you know that you need this piece of information in order to act. Then you start actually looking at your data. You will identify some of those data quality issues. And as you identify them, you can incorporate them into your data strategy and see how you can improve them. And so whether, I was just thinking before today, let's say that you're using publicly available data to identify what's some of the key needs that your X neighborhood for your pregnant women, pregnant women coming from this specific zip code might be facing. And so you create then a data collection tool where you're actually collecting non-medical drivers of health for this information. And quite often what we find is, for example, small percentage of my providers are collecting this information or really complete it thoroughly. And so maybe, as you evaluate that, what you might end up finding is that your data tool is a problem, right? And so instead of 15 minute survey, you need to create something that's 3 questions, and maybe your 3 questions tool then ends up not being good enough. And so there's always a process and there's always a cycle that starts from how you're acquiring the data and the data quality to all the way on how I'm using it and how you're implementing it. And it's always improvement that's out there. So I'm going to get going just for the sake of time. Okay, so now coming back and bringing all of these sort of general concepts that we were discussing back to non-medical drivers of health. I know most of you are very familiar with the definition for the social determinants of health information that we have out there. One of the things as someone that works with data all the time that I always find interesting about this definition, which I like, is that it's so broad and encompasses so much that if I have to translate this into data, it could really reflect 100 or 1,000 different data points or different types of data information, right? And so again, this brings us back to how to tackle this and where do I start, right? And so probably when we're thinking about non-medical drivers of health, most of you want to identify what are those primary needs for your community or for your patient population, right? But because they can be so broad, and if you are, the primary needs for your diabetics might be slightly different from the primary needs for someone that has, kidney failure, or, or of a child that has asthma, or of a pregnant woman, right? And so the idea, bringing this back to the idea of prioritizing a population that you want to start working with, or prioritizing a specific need that that's present there, or that you might think, that's present in your population, helps you narrow a little bit the scope and actually start with a data projects that's more specific and more tangible and realistic to carry out, right? Knowing that starting with one thing doesn't mean that you won't be eventually making it able to make it grow or to then move into different type of populations or projects, right? The other thing that I think, and this is going back to our action piece when we think of data, is the fact that we need to establish a response for whatever we're going to be identifying, right? And so if I'm collecting information on food insecurity, I need to be able to respond to that information that I'm collecting, right? Whether it's just by modifying how we as a provider make a recommendation for from a diet perspective, or actually establishing referral systems, or do specific interventions to help ameliorate that food insecurity. But we have to keep in mind that usually when you take on a data project or a data collection effort, you have to have a response to that project. And of course, ideally, and I know some of you are already doing this, evaluate the effects of that intervention, of that referral, of that change in decision making that I create, because that will allow you to reassess where you're at and reassess the needs of your community and see if you need to modify anything of what you're doing at this point. So going back again to this sort of idea of a cycle in data. Okay, and so back to the point on some practical advice, right? There is one of the first things that I always think, and this is more particularly for those of you who might not be already working a lot with different data points on non-medical drivers of health, is that there's already a trove of information on your patient population that's in your system, right? Even if it's just from appointment schedulings and check-ins, you already have a lot of rich information that's out there and that you can leverage to start understanding. And so if you can think of, the information that you get from scheduling and checking your patients, you already have some demographic information there. You have addresses and you know the neighborhoods these patients are coming from. You could actually also be looking at the insurance status of your patient population or the insurance type, right? Which can actually help inform quite a lot. And some of this very basic information can then be combined with some publicly available data sets that can help you enrich what you know about your community or your patient population and help you plan or design your data project strategy in the future or your next steps. So I'm going to give you some examples for this. Okay, and so now is where we go really brave, and we're going to be toggling between internet, our website, and the slide. And so one of the projects we have in the center, and this is just an example of one of the potential data sources that you have, was funded by the Cullen Fund a couple of years ago, and it was really to put together a library of publicly available non-medical drivers of health data. and we first originally started it with a focus on research to make it easier for researchers to access this data as they were thinking of their own projects. But there's a lot of these that can be leveraged into day-to-day practice. And so let me see if this works. Okay, can everyone see the browser or the website? I hope if you're not, you can just tell me that you don't. So the link, you'll have the link in the slides, but this is basically one of the tabs in our center's website. And what you have here is a data library of a broad variety of different public data sets on non-medical drivers of health. We basically put a lot of this information together, and a lot of the different data sets are really reporting very similar or related information. And so if you're interested in employment, you may find that you'll have employment information at different geographic levels and from different surveys or census or different data sources that cover very similar information. And sometimes it's hard to know where to go for it, or you can spend hours or days searching for specific data elements. So we basically curated these and created a search engine to make your life easier on that. And so the first thing I wanted to show you here is that you can check county, usually not that helpful for you guys in practice, but zip code might actually be more helpful. And we have different years, and though the last year here that's updated is 2020, actually we've updated the data when you click on it all the way to 2022. And what you have here, which I'm not going to open because it's going to look a little bit too much, is an Excel spreadsheet that you can download that has every single zip code in the state of Texas and a selected set of, I think it's 30 to 35 variables on different social determinants of health or non-medical drivers of health for that specific zip code, as well as total population and population characteristics for that specific zip code. And so if you look here, this is just a broad list of the different data sources and information by specific areas, so whether it's the demographic information, economic, education, health access, neighborhood and built-in environment, or social. And so you can select the domain here. Right now I'm looking at everything, but let's click like economic and education, right? And we have all different type of geographic regions that could be available. Let's make it more practical. Let's say you're just looking at zip code or SICTA. And we're looking at employment, home security, income, poverty, education. And part of the idea is, let's say that we go into poverty, right? And I click American Community Poverty status in the past 12 months. What you get here is actually the reference to where you can go and download the data directly if you're interested in the raw data, and the citation and the reference and the link to where this is, as well as the years that this information is available, right? All the way through 2020. The orange circle means that this is at the zip code or SICTA level. There's other indicators depending on different geographic information. And what you have here is where these are the different variables that cover that information. So for example, you can get information that's whether, percentage of families whose income is below the poverty level. And this is for example, the population below the poverty level in that specific zip code, right? The yes or no just tells you whether you find these in the Excel spreadsheet that you can download directly. And if it's not in the Excel spreadsheet and you're having issues downloading it directly from the census, this is basically census data, you can actually click here to get a PDF that explains to you all the process, or reach out to the center and we can help you access that information directly on their website. And so this is, if you think of this, you could, or you have someone that's data savvy enough in your organization, you could basically be creating an aggregated file where you have the different zip codes where your pregnant women come from, for example, right? Instead of making it all your OB-GYN patients, let's say people that were pregnant in the last year, where they're coming from. And you can pull out specific characteristics for those zip codes, which might allow you to identify areas that are more vulnerable and flag them, and that allow you to do or plan different follow-up for that patient, for those pregnant women. For instance, that's just an example. Though I know that some of you may be looking at things that are more visual and require less data merging and work. And so, for example, the other point I thought was interesting is this area deprivation index. And so, as you probably know, there's a lot of these non-medical drivers of health factors are very much associated and interrelated. And it's very likely that if you have low education, you'll have an area with low income, and probably there's going to be issues where they're with the built-in environment in that neighborhood, right? And so there's researchers and academics have a lot of arguments about these indices and how well they work and what they're missing when you're using them. There's a lot of these indices that combine these different factors that have been created and have been published. And this one, for instance, the Area Deprivation Index, was created by the Wisconsin's University, I think, and it's part of the Neighborhood Atlas initiative that they have. And so the reason why I link it here is because if you're looking at something that's more visual and can give you more one-on-one information, you can click here, for instance, here. Actually, that's where I need to click. And I was looking at something that's more visual because we are working on getting some more visuals out there, but we won't be doing anything like this anytime soon. So I think that this type of things are coming for Texas. And if you go into mapping and you select here, let's say Texas, we're going to need a couple of more minutes. Okay, and so here in Texas, what you have is the option of putting a full address and get what the vulnerability, the area deprivation index is for that specific address. And so I'm going to put right now here in the School of Public Health address. Okay, and so it locates immediately the specific address for that block and what's the area deprivation index for that block, which is basically a 2. It's relatively good. The blues here are the least disadvantaged, and here are the most disadvantaged groups. And you can actually zoom in. Let me see if I can zoom in more. Okay, too much zooming in. But you can see the Houston area, for example, and you can do the same for all the other areas in the state of Texas. Let me just click here. And you can see how the variation that we have in the area deprivation index. And it allows you to match, for example, if you need some of this information one-on-one, when you're seeing patients or trying to characterize your patient population. This is another publicly available tool that can actually help inform your day-to-day work. So I thought that was also something interesting to share. Okay, so I'm going back to my slides. These were just in case we couldn't do this virtually. And we're getting close to wrapping up because I want to make sure that we have some time for questions if you have any. And so basically when we're thinking, what I wanted to make sure is that we gave you some practical information on how you could leverage what's out there. And so here I was just really thinking about some examples. And basically the number one was really, I think I've mentioned this already. There's the opportunity to actually aggregate patient populations by zip code and identify what proportion of your total population or who or how many come from vulnerable areas, right? And so you might be able to create priorities within your day-to-day practice on who you have to be, more on top of, or specific areas or specific populations to whom you want to create an intervention or a change on how you practice with them, right? But because this can be so broad, if we leave it at that question, you may want to actually refine these and maybe focus on, how many pregnant women do I see that come from zip codes with limited transportation, right? And do I have to keep these in mind when I'm putting up the hours or when I do the follow-up calls to confirm appointments or reaching out to them with enough time, right? Or for example, you may want to look at how many pediatric patients do you have that come from food insecure neighborhoods, or how many diabetics do I treat that live in predominantly Hispanic areas and have, I don't know, low income, right? And so because that might help inform some of your food recommendations or food prescriptions that you're doing. And so this brings us back again to identifying those, using publicly available data and some of your retrospective data to identify some of those key non-medical driver issues among specific populations. And also thinking, as you plan on your next data step and data analytics, how can this affect my decision-making process or my interventions or an intervention that I may want to do? This could be all the way through what should I be screening for at the patient level, right? What questions do I need to make sure that I'm asking different people, as not all medical drivers of health will have the same impact on or be the same relevance to all our different patients, and very likely help you inform what should your next priority from a data perspective be. And so finally, wrapping up, I think the very last thing that I wanted to mention is, I know, and we all know, that leveraging healthcare data and related data, specifically non-medical drivers of health today, is complex, requires strategic planning, and usually it requires significant investment in time and resources, right? But there are some ways around it and some way to get it started, because, the other piece that you'll find out there is that the relevance to day-to-day practice, and specifically to your individual patients or your patient population's health, as well as to your own revenue cycles, will only keep growing, right? I think that data analytics, and being data-driven organizations, it's something that's becoming the reality and a need for most of us out there. And so this will only keep growing, and there's very little chance that this will disappear. And so basically with that, I just wanted to thank you. This is, again, more contact information from our side, and I really wanted to open this for discussions. And I probably rushed through it, but I think we have a good amount of time to answer questions. I'm going to stop sharing so I can see some faces. So most of you probably without your cameras on. There you go.
I've got a question for you.
Yes.
So increasingly, providers are screening their own patients for NMDOH because of all these requirements that are coming down. How do they, or how do you mesh like what you learn from that screening of your own patients with this external data, the area deprivation index, that sort of data, so that I'll stop there. How do you use those two sets of information together? Or do you need the external data if you've got your own screening questions from your patients or members?
That's an excellent question, Elena. I think there's you really can approach these from different perspectives, depending on where you are at with your own screening of your population, right? The idea behind this is that we are often screening for a broad number of factors, and it's hard to know, what's really. There's the day-to-day reality of individuals, and then there's the reality of the neighborhoods where they live in. I actually think that doing this pre-analysis, or this publicly available, or leveraging some of these publicly available information, can help you inform what's really best to be screening, or most effective to be screening on. That doesn't mean that asking all of these questions becomes irrelevant, right? But I think it can help supplement the information that you're screening for. Also identify individuals that you want to make sure that you don't miss when you're screening, right? And I know the recommendations are to do universal screening, really. But when time is constrained, when you sometimes have little time to see your patients' populations, and it is really important to be able to flag who are your priorities and who you should be really making sure that you don't miss in that screening, or follow up if that person missed that screening information. And so I actually think that they can supplement each other from a data perspective, though it's always best to use if you have one-on-one data from screening to use that and leverage that. But if you have missing information there, or if you are able to, or if you have missed opportunities, right, individuals that did not end up being screened, it's always a good way of being able to identify who are at highest risk of having some of these things, and who should be your priorities for follow-up, right, on those screenings. I think that's one thing that's important. And then the other thing is, when you analyze things from a geographic perspective, from a broader geographic perspective, it can help you inform you on some of the things that you may want to start thinking as a provider that cares for a community, right? And so you have your one-on-one care that's going on, but probably you can also want to think about, if I have X number of diabetic patients that are coming from this socially vulnerable area, and though I'm not identifying that in my screening, it might be something that I'm missing there that I could be working on as well. That's my 2 cents. I think I saw a comment or a question in the chat. Let me see. And for some organizations, it may also be helpful to compare internal data to publicly available data for the same area to see if the population you work with is representative of the area served. That's very true. Thank you for that, Scariana. What are some examples of funding sources being utilized to pay for access to these CHCAC data? Well, so there's a broad variety of different sources. We have organizations that have, so the first thing I should say is that all the non-medical drivers of health data that I mentioned, that's available for free. There's no cost to that. That's publicly available data. For the other more specific data sets where we work with claims data or some EHR data, and they're more project specific, we have a broad variety of things that go all the way from federal funding at NIH and CDC to state agencies or some organizations that are using their some of their own resources to access for that. And then, of course, we always have smaller projects or pilot projects where we thrive to help as much as possible in the hopes that in the future it can help set up some funding revenue source for a larger version of that project. And we also have foundations, as I mentioned. Yeah, there's a lot of work from different foundations also supporting these.
I received another question via direct message in the chat about the plans for data update. Is the 2020 data the most recent, and how frequently do you update those data sets?
And so we update those data sets as they get updated. And so you'll find that some of these publicly available data sets get updated every 5 years, for example, or some of the, particularly if you're using census data information on there. But for example, those that already were updated for 2022 have been updated in there, though that's a glitch we have there, though it says the drop-down menu says 2020. When you actually click, if the 2022 year is available, you'll see it there in the display, and it's also on the downloadable Excel spreadsheet file. Oh, and that's a really good question between the deprivation index and the social vulnerability index. And so you'll find both indices are in the, what's the difference? I have a question here in the chat about the difference between the area deprivation index and the social vulnerability index. So there are different indices that have actually pulled slightly different non-medical drivers of health elements into the creation of the index, and they're weighted slightly different. And so they are, depending on what you're using it for, particularly in research, when you incorporate them into models, there's preferences or not. I think in general for practice, they give very similar information in that sense. And the only reason why I highlighted, right, you'll find both in our search engine. The only reason I highlighted right now the area deprivation one is I actually found that it was very exciting to be able to fill in a full address and get the specific area deprivation for that address.
Thanks. I wasn't familiar with that one. I've only used SVI before, so good to know about another one. Thank you. Other questions, comments? I mean, one of the things we're hoping that you get out of this, despite the fact that Cecilia is so smart and sophisticated, talks so fast, is that you can do this. You know, you don't have to be Cecilia to do this. Whoever your patient population is, you can do some of this for them. And we want to keep on bringing you resources that help you do it so that you don't have to boil the ocean. You can actually figure out, you know, decide to start somewhere, some population, some condition, some driver of health, and go from there. And Cecilia offers many, many resources for that.
Yeah, and I also want to, you know, welcome anyone. I know sometimes this is overwhelming amount of information, but if you think of questions later on, I'm more than happy to answer those and give a hand in any way. Denise, I see your hand up.
Hi, Cecilia. Denise LaRue from Harris Health. I have a question as we're thinking about using broad NMDOH data, like at the population level. If you had any thoughts about how well you have to kind of penetrate that larger population in terms of screening. And the reason I ask that is that as a large healthcare system, we often have to make decisions about how we're screening from a workflow perspective and patient population. So I'll give an example where, you know, because of the CMS mandate, we're screening very well on the inpatient side. We have some notions that we want to that we've embedded screening, for example, in our prenatal workflows and our oncology workflows, because we know that those are very vulnerable populations. On our kind of like larger scale primary care population, though, I would say, we're screening if a patient shows up to the case manager, if the patient has my chart and they can get screened ahead of time, we're doing that really well. But we know that that's not capturing everybody because, for related reasons, not everybody is using technology to do all of their things online. So I just, starting to use the data like in a strategic way, thinking about that broader patient population, do you have a sense of, what proportion of patients should you be screening to be able to draw conclusions about how you should drive some work going forward?
Oh, so I think I see your question. In the sense is, what would be a relevant sample size to actually be able to create your strategy? I think it will depend and will vary a little bit based on your overall patient population. Like in the case of Harris Health, you actually sort of by design see a big proportion of your patient population already comes from vulnerable areas that have high social determinants of health needs, and so you might actually end up needing to screen a smaller proportion, right? To see, you need someone that has a fewer, their distribution of patients is smaller than from vulnerable areas than yours. And so I think in that sense, for example, understanding what your overall, which you probably know by this time, Denise, because I know you guys do a lot more analytics in this sense, but in general for everyone, is understanding what proportion of your population comes from social or vulnerable areas will allow you to do two things. Is, okay, how many patients do I actually that come from social vulnerable areas? Do I have to screen all of them immediately to get a sense? Or if I'm screening, half of those, I'll already have enough, a good enough idea. And maybe it allows you to identify, if you don't have everyone coming from social or vulnerable areas, who, highlight patients that immediately, as you know that they're coming in, they need to be screened, right? In your case, you have a point. You actually could be screening just a sample of them to get an idea. Other people with different distribution should actually be maybe just identifying those that really need to be screened, right? Because they come from vulnerable areas and where there's specific benefits or at least the benefit from screening them will be greater than others. So I have a hard time telling you, it should be 15% or 30% of your population, because it depends on.
Yeah, that's helpful to think about it, that, we should be thinking about multiple data sources as we're thinking about our strategy, and not focus so much on kind of like that, having a target number of or proportion of people to screen. So thanks.
Yeah.
Anybody else? All right, Jackie, I guess back to you. Close us out.
Oh, I had one other question come in, actually. Whether, and I think this may even be in response, Denise, to one of yours, shouldn't all patients be screened to ensure SDOH need is considered in patient care, not just the analytics?
Yeah, so yes, I don't know who asked that question, but yes, the general recommendation is to do universal screening. But this goes a little bit more about, it goes beyond from screening, right? It goes from what do you do with the data that you collect from screening, right? And so when you actually you've screened everyone now, and so now you have social needs that you've identified from a broad variety of patients that can go from hypertensive patients to diabetics, or you can have middle-aged men or pregnant women, right? And so it's, what do you do? And so it goes a little bit beyond from you do the screening for everyone, but when you think of a data project and how you use information, is what are those key elements that I have to identify, and how am I going to act on those? And then you can actually start thinking of your analytics. And sometimes to identify how you will act on those, you need that screening information, but you need to know what to be screening on, and you need to create actionable interventions or decision processes or something, responses to that piece of information that you've collected. And so you're absolutely right. The recommendation is to screen everyone, right? You don't want to miss everyone. But if you're really starting here, and so again, this goes back to who you are, the size of your organization, and how you can respond to that. it changes a little bit. And so sometimes understanding your overall population, where they come from, will allow you to start planning what are those type of responses that you have to have ready so that you can actually then respond to that universal screening that you're doing. Hope that helps.
Great. Well, if there are any other questions, I'll give a pause here to see if anyone wants to unmute. Okay, well, thank you, Dr. Ganduglia-Cazaban, for your presentation today, and thank you, audience, for all these great questions and the robust discussion that came out of it. Before we sign off, I want to alert you to the NMDOH Program Index, which is a catalog of NMDOH programs across the state that are sponsored by health system organizations like plans, providers, and hospital systems. The abstract features features abstracts of programs with searchable fields. But that said, the program index will only be as robust as you make it. So if your health organization offers NMDOH programming to your patients, please reach out to me at jk90@rice.edu, and we can work together to get your programs showcased on the program index. And I'm going to drop a link in the chat for y'all to reach out to me. Our next learning session will be this coming Tuesday, July 23rd, on practical steps to integrate NMDOH screening and referral program, presented by Dr. Stanley Williams from the Harris Center for Mental Health and IDD. So check out our events page. Thank you all again for a robust discussion today. We are grateful for your input, and we will send you a short survey over the next couple of days. This consortium is going to be what we make of it, so we look forward to hearing what you want to hear from us in order to deliver that. Please stay in touch. You can always reach me at jk90@rice.edu. Thanks again, and have a great rest of your day.